Hello and welcome to another webinar with Viva Learning. I am Jamie Collins, and we're going to talk about reaching beyond the operatory with Homecare solutions and some of the common things we see there. My email is there on the screen. Please do not hesitate to reach out if you have any questions. While we are on the webinar, if questions come up, please put them in the Q&A box and we will address those at the end. My background, I've been 23 years in the dental field, most of that time as a dental hygienist. I've been very fortunate that I get to speak and meet people such as yourself. I do work as a KOL and subject matter expert for various companies. I've worked heavily in education and curriculum and course development, published over 70 articles to date with multiple publications. And I've been a contributing author to multiple textbooks with Elsevier. I've signed contract, actually working on number 11 with them right now. I do work with the Dental Coding Consortium, which we work with code creation and testimony to the ADA and Code Maintenance Committee each year. And I am the professional education manager with Mouthwatch. I do want to extend a big thank you to Sunstar for sponsoring this webinar and making it possible to bring all this information to you as well. So some objectives we're going to look at. We're going to discuss the oral and systemic health links and really that importance of optimal oral care with those. We're going to identify some of the home care solutions for hypersensitivity, periodontitis, caries prevention, some of the most common problems that we do see. And then going to review some of the over-the-counter and prescription options for high-risk patients. Some of my favorite things in my toolkit that I send patients home with. So why do they come see us? One of the biggest factors is something doesn't feel right. It hurts or it's uncomfortable. And so this is a driving force. Pain is an incredible motivating factor for people to come to the dentist. They may also notice loose teeth, bleeding gums, halitosis, which is much more common now that people have been wearing a mask, become a little more self-aware of their own oral condition. Pain, as we said, the motivating factor of pain. It may be a red and swollen gingiva. Maybe it doesn't hurt, but the appearance doesn't look quite right. Sensitivity is another very common factor for reasons we see patients and a very common complaint, as is if they notice recession. And as you know as well as I do, sensitivity and recession many times go hand in hand. One important thing that we do have to consider is medical and dental interactions. We know the mouth and the head is really connected to the rest of the body. We also know that many times we see oral manifestations of disease or non-health prior to anywhere else in the body. So we're a little bit of an investigator when we see patients. And we know the importance of oral health, of good oral health as well, because of the links with diabetes. We know it can complicate Alzheimer's and dementia, chronic kidney disease, and these are all according to the ADA. All of these systemic conditions can affect oral health. Likewise, oral health can affect these conditions as well, even if they have the inability to maintain appropriate oral hygiene with things like osteoarthritis, osteoporosis, Sjogren's disease, HIV and AIDS, and we often overlook sleep disorders, which is another very common thing that we do see, and we see more and more dental providers screening for this. Every day, more than 4,000 people are newly diagnosed with diabetes. That number is astounding when we think about it. And there's a lot of contributing factors to that. In the US, it's 1.5 million Americans each year. If we look on a worldwide standpoint, according to the International Diabetes Foundation, the prevalent estimate by 2025 is going up considerably. Some countries in the world you see are greater than a 20% expected rate versus others that are going to be more in that 10 to 14% of their population. So we're seeing so many aspects, and it's not just a single country's problem. It's a worldwide problem that we also see the implications in dentistry. We also know adults that are diabetic are twice as likely to have a heart attack or stroke. Their risk factors increase significantly. And 90% of diabetics have oral manifestation of the disease. 90%. Many of those we can actually identify long before they get far enough in the disease process that it's really caught early. We know there's many, many thousands of undiagnosed diabetics around the world. We also look at the systemic complications of diabetes. We know retinopathy is number one, that visual impairment, including blindness with it. Kidney failure, again, neuropathy, sensory loss, damage to the limbs. We also know the macrovascular disease, heart disease and stroke. We know this is a leading cause of death in diabetics. Poor wound healing, foot ulcerations, gangrene, lower limb amputation. We also see that in the oral condition. Poor response to surgery or non-surgical periodontal therapy with diabetics is much, much higher than the general population. And periodontal disease is the sixth leading complication of diabetes. Again, we know they go hand in hand with so many of our oral conditions and our systemic conditions. One can complicate the other, There was a study that recently came out that said adults face an increased risk of developing diabetes post-COVID by 40% versus if they did not have COVID. And this is within the first 6 months after COVID or they've been infected with it. There's been a spike in cases. So we're going to see these patients in our dental chair. And it complicates how we treat them, but it also complicates and really relays the importance of good home care and home care solutions and finding what works well for them, which we'll get into some of those as well. Arthritis. If you have rheumatoid arthritis, we know that's an inflammatory autoimmune response and is linked to severe inflammation. It can cause joint damage, but it also can affect, and you're at a higher risk of Sjogren's syndrome, loss of motion in the TMJ, and a higher risk of oral infections, bacterial and viral, gingivitis, and periodontitis with arthritis. It also complicates home care because the joints aren't working properly. And if they have an inability to provide proper home care to themselves, we need to figure out a solution. And there's so many other options than only brush and floss. Sjogren's syndrome, as I said, is an autoimmune disease, and it destroys the exocrine glandular epithelium. People with Sjogren's have increased risk of caries, severe xerostomia, candidiasis, enlarged salivary glands, gingivitis, periodontitis. And we know that inflammation process affects the glands that leads to oral dryness with that xerostomia. They may be at a higher rate of angular cheilitis too. Sjogren's usually takes a little bit for somebody to get diagnosed with it because the symptoms can be a little bit more vague. But everything we just talked about has one common denominator, and that's inflammation. The measure of inflammation is the C-reactive proteins. They're found in the blood, and it measures the inflammation in the body as a whole. Periodontitis, diabetes, Sjogren's, arthritis, heart disease, they're all going to have elevated C-reactive proteins in the body. We know that's also a direct risk for cardiovascular disease. So we're talking about the inflammation, the neutrophils, the macrophages, other inflammatory markers that we see. That's really going to be the future of how we treat patients in this measurement as well. We talk about inflammation and we talk a little bit about sleep apnea, acid reflux, and tooth wear. These are other common things that dental practices are beginning to screen for, but we're also seeing how it affects the oral tissue and the overall health. We know that up to 70% of nocturnal reflux, acid reflux, is related to sleep apneas and hypopneas. And many times we will see these patients that will have a unilateral wear on one side of the mouth that doesn't match the other. And you think to yourself, how does that happen? What is going on? Have you discussed sleep patterns or done the screening? Because that's a very common thing we see with acid reflux and or sleep apnea, which many times go hand in hand. That acid erosion, and the patient lays on one side, or the individual does, and that acid's more pool on the side of that mouth, and it's going to affect the enamel layer there. So that's why you see that. Sleep apnea also increases your risk of asthma, certain cancers, chronic kidney disease, cognitive and behavioral disorders, stroke and heart attack, metabolic disorders that may be type 2 diabetes or insulin or glucose resistance. And then, of course, inflammation. Those that have sleep apnea that is untreated often have higher inflammatory markers in the body too. Another common reason that patients come see us is they may have that acid erosion, or you identify it, whether it's through sleep apnea or something else. And there's different factors when we're talking the best home care solution for individuals, because it really is a customized approach and a team approach with you, your patients, the practice, maybe sometimes a caregiver. We have to look at the acid exposure, whether it's extrinsic or intrinsic. We know the extrinsic factors for acids from outside of the body. So we have to consider dietary, the pH, the frequency of exposure, and the buffering capacity of the saliva. When dietary, we talk about acidic drinks, soft drinks, sport drinks, fruit drinks as well, but also things like vinegar, salad dressing. We see it with medications, those that take a lot of vitamin C or aspirin, and certain occupations, wine tasters, professional swimming, if the pH is not controlled well, and certain chemical or metal industry workers. Intrinsic factors, this is going to be the acids produced by the body. And they have a significant impact on the oral cavity. Certain medications can actually induce GERD or laryngopharyngeal reflux. And that's the disorder of the gastrointestinal system. So that reflux is either coming up into the mouth or even just into the esophagus. And with the fumes coming up again, they increase the risk of certain disease processes. We know those medications cause it. We also have to consider bulimia, the purging type, the vomiting. And then expectant moms, morning sickness and the acid exposure from that can have a significant impact. A common question that I use when I'm talking with patients about this, and if I suspect acid reflux because of implications I see on the oral cavity, unilateral wear, acid erosion, I ask them about GERD. And that's the heartburn, the pain result of that acid exposure in the esophagus. They may have heartburn, as I said, chest pain, nausea, or they feel like they're constantly swallowing. Compare that to laryngopharyngeal reflux. Many times that's more silent. They don't realize it's really happening because they're not getting the acid all the way up. But it can come into the oral cavity and the sinuses. And common symptoms there include more of a heartburn, which may or may not be present. They may wake up with a little bit of a hoarseness to their voice or feel like they have something stuck in their throat. They're trying to swallow it down. Trouble swallowing, frequent clearing of the throat, bitter taste, and a consistent postnasal drip. When you're thinking of acid reflux, and you're probably thinking of a few patients you've seen where this fits, do you discuss it with them? Because many times it's tied to apnea, but also certain developmental disabilities have a high incidence of GERD, especially if they're intellectual disability or developmental disability. For adults with a moderate range intellectual disability, about 50% of them experience acid reflux or GERD. And the literature really varies. You see anything from 15 to 75%. Most studies are right around that 50% mark. Autism spectrum disorder, about 33% experience acid reflux to some extent. The parents may complain that the child always has bad breath or the individual has bad breath, not realizing it's more than just the teeth or the tongue. So some very common dental concerns that we also see in the practice, and we see on a daily basis. We see the patients come in, and we know 2 in 5 adults have periodontal disease. Over 70% of adults 65 and older, and 47.2% of adults 30 and over have some form of periodontal disease. I've been in practices, I've subbed in practices that say, our patients don't have perio. Well, I've only subbed there once because we know that it has no boundaries. We know that it's socioeconomics, we know race, we know ethnicity, dietary. There's a lot of factors that go into it. Severe periodontal disease affects 14% of the world population, and that's a severe form. These are patients we have to consider when we see in clinical practice. With COVID, lots of studies are showing that patients have not returned to dental care or maintained dental care during the past couple years. What that means is they may be coming to see us in a more severe state. Or if they were maintaining previously, it may have taken hold, and we're retreating these patients in that manner. Cardiovascular disease and periodontitis really go hand in hand. We know how much it is linked with poor oral care or advanced untreated periodontal disease, with diabetes, especially when we're looking at the cytokines interleukin-6, especially with diabetics. And periodontal disease, as I said, is a 6th leading complication of diabetes. It's been well documented. There's adverse pregnancy outcomes, low birth weight. Preeclampsia is more common in those expectant moms who have untreated oral conditions. Pulmonary infections, bacterial pneumonia, COPD. There is some studies and some evidence out there that looks at the inflammation and COVID in the body, especially with perio-2, early studies on that. Rheumatoid arthritis, we know promotes the dissolution of bone. Destruction of the bone and periodontal disease, again, are hand in hand. We know that it also, with osteoporosis, it has an osteoclastic response, that destructive response. And in Alzheimer's patients, there's been many studies that are showing the periodontal pathogens in the brain of patients with Alzheimer's. And every one of these has inflammation in common. We are seeing that experience with that as well, and how that affects. Another very common symptom we hear from patients is hypersensitivity. 1 in 8 people complain they have sensitive teeth. 1 in 8. So this is at least 1 out of your day. You know the type. You come in, they sit down in your chair and they tell you where you can and cannot touch because things are sensitive. Or it's kept them out of the dental practice for many years out of fear of pain. This can be caused by fractured teeth, whitening, deep fillings or other restorations. Bruxism is also a common cause. We know with erosion, as I alluded to, or thinning of the enamel, decay, periodontal disease, recession, just to name a few. One of the most common aspects we see with hypersensitivity is if we have wearing away of that enamel layer. That may be through attrition, which is the tooth-to-tooth contact. That may be abfractions. So the occlusal loads are unbalanced, and it leads to microfractures of the cervical enamel that flakes away. The notches right at the gum line of the teeth that you see up there, and the patients stick their fingernail up there and they say, it hurts when I do this. There's a notch here. Those are the abfractions. It may be due to abrasion, which is produced by the exogenous material forced over the tooth surfaces. This may be excessively hard toothbrushes. It may be other materials that they're utilizing. Some of the charcoal toothpaste that you can purchase have a really high abrasion factor or abrasion rating. Things like that can affect. And it may be due to erosion, which is that chemical process, not bacterial, but chemical processes. This may be lemon water. It may be a high acidic diet. This also may be the acid reflux. Again, many other ways they utilize it. Another common complaint we hear from patients is halitosis or bad breath. This may be a part of the excessive oral bacteria. We know the tongue harbors 50% of all the oral bacteria. And there's about 20 million bacteria in the mouth at any given time. Of those, there's about 1,000 different types of bacteria. Most of the plaque is gram-positive, or gram-positive is found mostly in plaque. Gram-negative is the odor-causing, and that really likes to live in the pits and fissures of the tongue. I've had many, many patients that don't realize you need to brush your tongue as part of your home care routine. Do you ever ask or remind your patients to do so? I've had to learn that over the years, and once I came to realize that they don't, it's really made a big difference, even if the tongue isn't necessarily coated. And many patients don't realize they have xerostomia, which is another very common factor. With xerostomia, we know that 10 to 26% of men and 10 to 33% of women say they suffer with xerostomia. It's often so gradual that it comes on that it's deemed normal. And saliva has a lot of protective factors. We know that it's qualitative and quantitative, and composition matters, that calcium, phosphate ions, we know those are all a big part of it, amongst others. We have to look at the buffering capacity and the flow rate. We also know the acquired pellicle on the teeth is dependent on the thickness and that plaque biofilm formation. It often protects against the erosion from the acids just a little bit, but if the saliva is not there to wash away the acids, we're going to see lots of problems with it. With hyposalivation, maybe systemic, which is xerostomia producing medications that we see. It may be through illegal drug use. There may be pathology of the salivary glands. Have they had radiation removal or some other condition that is a systemic disease that has been undiagnosed or diagnosed? We know smoking affects the salivary flow. But did you realize vaping can have a significant factor on it as well? With that, we see a higher rate of caries, we see a higher rate of periodontal disease, and many times other infections as well. It may be caused by a localized issue like mouth breathing, lip incompetence. There's a big focus and a shift in dentistry to look at things like myofunctional therapy, sleep apnea, sleep disrupted breathing. We are treating the whole patient. We're treating their mouth, but we have to look at the whole picture. We also know that inappropriate oral hygiene care, especially in an acidic environment, is going to have a significant factor, whether that is on decay, periodontal disease, infection. We know saliva is the body's #1 defense for an acid attack. The greater the salivary flow, the more bicarbonate ions that are available to combine with those free hydrogen ions. This is what's going to help wash it away. So we know when acid's introduced to the oral cavity, the salivary flow is stimulated and it increases. There's salivary flow rates that you do need to consider when we look at that and talk about those. And there's many tests out there to test this at home too. One significant factor is the polypharmacy effect. Do you know how many commonly prescribed medications list xerostomia as a side effect? Commonly prescribed. That's over 1,800. They may be medications for HIV, hepatitis, diabetes, asthma. We know antihistamines. Many of the stimulants, especially used for ADHD, also have xerostomia. We know the benzodiazepines, the blood pressure medication, the opioids, antidepressants. We need to review medical histories each and every time that patient sits in your chair. An example of this is ditropan IR, which is used for overactive bladder, has about a 72% reported xerostomia rate. Our older population, who's probably the one taking this, is probably on a laundry list of medications, but maybe they also have arthritis. So they're dealing with a lack of ability to perform basic oral hygiene skills. And so we have to consider this when we're planning that home care solution. And we look at bruxism too, with the grinding and clenching, which may or may not be loud enough to wake up a partner. Clinically, you're going to see teeth that are more flattened, or you may see more fractures, chipped teeth, or loose fillings. The enamel looks worn. In many cases, it'll look a little bit dull in areas, and it exposes that deeper layers of the enamel layer and many times on down through the dentin. These are oftentimes our patients that may have unexplained tooth pain or sensitivity due to clenching and grinding. The jaw might be tired, or they may end up getting locked up or won't open or close completely. Sometimes they can complain of jaw or neck or face pain or soreness, or pain that's like an earache. They go to the doctor thinking they have an ear infection, and in reality, it's more of that bruxism and the after effects of it. Many report a dull ache that starts in the temples and damage when they chew the inside of the cheek and sleep disruption. So we have a little bit better understanding of some of the aspects that are going to create oral conditions for patients we see in our chair every day. So what do we do? What can we do? I am a firm believer the first thing you can do is educate your patient. We assume because we're in dentistry, they know everything that we know. In reality, they don't. They don't. I can tell a patient that you have periodontal disease and bone loss, and we need to do scale and root planing to preserve the ridge and what you have. And they nod and they smile, but they really don't understand. I use an intraoral camera, just like I use my loops and light. They're an absolute important part of what I do when I work clinically. And I use the x-rays in combination with that image from the camera, because when they can see what you see, it's a motivating factor. These two images I took personally. I talked to the patient, was new to my chair, had been recommended that they have scale and root planing multiple times, and said, yeah, I'll think about it. I used the camera, I pulled up the image, I discussed why, I showed my perio chart, and then I pulled up the intraoral image and pointed it out. That patient at that point became invested in their own care. It was a motivating factor. And that is one of the biggest keys, is you have to find what is that factor that's going to make a change and really spark the interest of your patient. We have to talk about prevention. So if it's something that's intrinsic, systemic, like reflux, GERD, if you suspect it, please don't hesitate to refer, just as you would refer out for things like oral cancer screening. If you suspect there's an issue, encourage them to see a medical doctor. Many of our patients come to see us on a regular basis for dental, but it's been years since they've had a physical. And we may need to figure out a way to mitigate the effects of the acid exposure with oral rinses, gels, and so forth. That oral hygiene routine and what they do between visits is so critical. If it's bulimia, refer for therapy, but listen, be compassionate. And if you suspect airway issues, if you don't treat it and screen for it, refer them. We know the implications of sleep apnea are far-reaching in longevity of life and overall health and wellness. And modify behaviors. We want to think about the timing of acid exposure, which can lead to decay, can lead to hypersensitivity. Drink acidic beverages and foods at mealtime. In between meals, it should be only water. Again, what we think of many times is not second nature to others. Discuss the food choices, acidic versus non-acidic foods, and certain sugar alcohol gums, xylitol especially, after an acid exposure, because it can help promote the buffering capacity of the saliva. There are some things that say drink cold beverages instead of hot, if you're going to have them. And reduce that exposure sometimes by using a straw. Do not swish the acidic beverages, as we see so many people doing. Exposure is a key part, and sometimes changing just the smallest factor, like water between meals. I often turn to the patient and I say, I like that glass of wine just as much as you do. The best way to have it is with a meal rather than sip on it for hours, and tell them why. And the extrinsic factors of our acidic drinks too. We know the carbonic acid adds a fizz to many of the sodas. Phosphoric acid enhances the flavor, slows the growth of the mold, so they add it to the sugary beverages. Malic acid is found in fruit drinks, nectars, iced teas, sports drinks, which so many consume. It enhances the flavor and increases the pH stability. Whereas we see things like citric acid, again, it's another flavor enhancer, especially for like the lemons, the limes, and the citruses, but it works in conjunction with phosphoric acid. It slows the growth of the microbes in the sugar and increases the shelf life. So choices make a difference. We also want to look at preventing future damage and pain. We talked about modifying diets. We talked about, and we need to assess the oral hygiene procedures and modify what they're doing if required. Provide education. Don't just throw it in a bag for them to take home. Tell them why you like it and educate them on how to use it. A key component is we discuss medical issues and medications. I can't tell you how many times I'd have a patient come in and you ask them and you update the medical history. And what do they tell you? Nothing that affects my teeth. In reality, we know head, shoulders, knees, and toes, we're all connected. So we want to discuss that and why. Again, if you suspect diabetes, we can actually test for that in a dental office. If you suspect GERD or reflux or airway issues, please refer them, just as you would if you found something on the thyroid. Health is health, and it's the important part to maintain. We're also going to look at assessing salivary factors, and we're going to use products that assist that if needed. If they have a low salivary flow, then we need to recommend a salivary substitute and probably consider something to help protect what we do have on the dentition. And definitely address the cause of sensitivity. There's a lot of products on the market. There's a lot of products if you look online, and many times patients are confused. They don't understand why or what to choose compared to the other 10 things that claim the same thing. And in reality, what works well for me may not work well for you. It is a very customized approach. And consider alternatives. We have floss, but there's different types of floss. Woven floss works fantastic. It also creates that opportunity and cleans a little bit better in certain areas. But for some people, it's not the best option. I find people that tell me, I don't like to floss. What else can I use? Jamie, I'm not putting my hands in my mouth. Great. Let's make it easy. We have floss picks. They have a pick on one end and that C-shaped flosser on the other. It's an easy one-handed thing. I am a big fan of interdental brushes because with so many restorations, and especially patients that maybe have perio and recession, the interproximal space is larger. Great, we can floss in there, but is floss the most effective option? To be honest, in my opinion, I don't think so for everybody. It's very much a tailored approach. For some, that rubber tip stimulator is a great option and really promotes that overall health. For any of these, in the interdental brushes, if they have root exposure and higher caries risk, many times we'll recommend they dip that brush in just a little bit of home use fluoride and go in between, or even if they're utilizing it around a furcation, putting that right at the spot that needs the best treatment. Very commonly used. Again, interdental brushes, huge fan of. Soft picks, again, one of my very favorite, my go-tos that I use personally and I recommend on a daily basis. But the key, again, is not only to make it simple, because if you give them a list of 15 things to do, they may do it for a day, they may do it for a week, they may do it for a month, but it's not really sustainable. We also consider toothbrush selection. Something that is a soft brush that's going to be effective, the right angle. If the patient has arthritis and grip is an issue, many times you can do something that will go and allow them to grip the brush, the toothbrush inserts in there. In some cases, it may be a power brush. You're going to find with a lot of your special needs or elderly population that they don't really like that power brush because it's something that they didn't grow up with. It's something that's new, or the stimulation from it is not desired. So look at your toothbrush selection. You want bristles that are going to be effective, and you want it soft that's not going to damage the restorations, the natural teeth, or the gum line, because we know we need to focus on the gum line and we need to educate our patients to do so. Oral irrigators or water flossers are also very, very effective. And I highly recommend those to my patients that have extensive restorations or have periodontal disease. Interdental brushes, as I said, is one of my go-to options. Floss picks, soft picks, wooden picks. The key is to find something your patient will use and to be effective. I often will send them with about 3 options, and I'll tell my patient, I would like you to try them all and figure out what works best for you, and then go with that moving forward. Will you call and tell me what that is so I can make note? So it gives your patient action items. As far as mouth rinses, I almost always recommend an alcohol-free rinse. Chlorine dioxide rinses, but definitely an alcohol-free. Much of our society is on medications, or they have xerostomia to some extent. The heavy alcohol rinses can complicate that and make that xerostomia and that dry mouth worse. And what happens when a patient has dry mouth? They're constantly drinking something, usually not only water, or they're sucking on something like a candy that's going to increase the rate of root caries or caries in general. I've had many older patients, especially, that have gone to that. And every time I see them, every 3 or 4 months, we have 3 or 4 new cavities that we have to deal with. I'm not asking my patients to use every one of these. I'm looking at the best solution on an individual customized basis. We also have to look at ortho, whether it is clear aligners or traditional brackets and wires, because ortho requires special care, as does something like periodontal surgery. We really want to customize that approach, and flossing and using the loops that we have works great for some, but for some others, the brush and the travel interdental brushes are a fantastic solution too. I often recommend these, especially as teeth are moving, to really get in and around those wires and those brackets. We see adults, we see teenagers in ortho. We're seeing kids that are younger and younger in initial stages of ortho. Finding that solution that works well for them. We also have implant care to consider. More and more of our society is getting implants, a really solid replacement. But many don't realize they have to care for their implant, and they have to care for that in a very special way. I often recommend, as I said, the soft picks, something that is not metal that's going to damage that implant body, that's going to get underneath that crown, sitting on top of that implant most effectively, to ensure we're protecting that tissue, we're maintaining health. If this patient has a systemic disease, they're going to be at a higher risk. We know diabetics are not the best candidates for implants, for oral surgery, or any surgery for that matter. We also know if they have dental disease, the blood glucose levels are harder to control. They struggle with having a better control of their glucose. So if we can get good control on one, generally we have a better control on the other. So implant care is so very important regardless of health status. I'm a big proponent of fluoride varnish because I think it works well for conditions like hypersensitivity, Post-periodontal surgery, one of the biggest complaints that I would hear from patients is my teeth were really sensitive after we removed that wall of calculus that was acting as a little bit of an insulator, especially on those anteriors. It's going to help protect too, especially for those medium to high risk caries patients. So I like it for post scale and root planing, and definitely for any root exposure. The simple brush and simple unit dosages, I like the ones that contain xylitol, and they're very smooth going on. This becomes part of my professional procedures I use, and it's going to help with the home care procedures afterwards as well. So when is toothpaste not enough? You know you're supposed to brush, you know you're supposed to clean interproximal. Now, whether it is a interdental brush, whether it's soft picks. But if you're at a higher risk, or our patients are at a higher risk for caries, we know in the US, sodium fluoride, stannous fluoride, monofluorophosphate fluoride are all different types that we have approved for over-the-counter. Over-the-counter toothpaste can be 1,000 to 1,500 parts per million fluoride ions. Prescription strength, we're looking at a 5,000 part per million sodium fluoride. This is incredibly important if they are higher risk, if they have acid reflux. We're going to use that soft toothbrush and a prescription strength fluoride if indicated for at-home use, prescription strength fluoride toothpaste for at-home use. It may be indicated to use things like salivary substitutes in addition to really help combat the effects of acid, xerostomia, and be in a higher caries and periodontal risk. Again, it all goes hand in hand. In my office, we would have a few tubes of the 5,000 parts per million sodium fluoride toothpaste, so my patient could go home with it from the dental office. They're more apt to use it if they have it in their hands. It is such a customized approach. My patients that are going to be going through cancer treatment, if they can tolerate it, we use something like this and an alcohol-free rinse as well. So in review, we look at the systemic causes that are going to lead to the oral implications that we do see. We're really putting on our investigator hat because we see representations of health or non-health in the oral cavity. Many times before a patient is actually diagnosed, you may be seeing signs or symptoms. I've referred patients out for this. But also identify the barriers to home care. Because if they don't like sticking their fingers in their mouth and they think floss is the only option, or they have arthritis and they can't properly hold a toothbrush, what other alternatives do they have? We have floss holders that you spool around that go in there. We have floss picks, which are a fantastic solution. And to be realistic, most of my patients would choose floss picks over string floss, given the option. So this is a point of discussion. Discover those barriers and then recommend modalities that are going to fit into their lifestyle and the routine they are willing to do. Keep it simple. It cannot be a 5, 6, 7-step process. Realistically, I will tell you, almost nobody will follow through and do that. But I give them options. I'm going to give you 3 options in our little bag of party gifts I'm sending you home with. I want you to try all 3, figure out which one you want to use, and let me know. So I make it very easy, but also give them that action item. But the biggest key is to educate. You need to educate your patient as to why you are making the recommendations that you are. Utilize that intraoral camera. It takes the selling out of dentistry, and it really helps that patient become invested in their own care much, much more. I have seen it through 20 years of practice and the change that it makes. Screen and refer. If you suspect sleep apnea, things like acid reflux, diabetes, it is within your duty to refer that patient for further referral. You cannot make that diagnosis in office. We can screen for diabetes in office, but we have to refer them to a medical provider for a definitive diagnosis. So we look at all of these options that we do have. And please, if you have questions, put them in the Q&A box. We're going to get to that in just a second. My email is there at the bottom. I want to thank you for taking the time to join me. And I wanted to save just a few minutes for questions at the end as we address that. Can you recommend a good cordless water flosser? I think at this point, there's so many on the market, and we have the ability to do so, whether it is certain brand names. I do like the cordless ones because they don't take up so much room. I think any of them are great, to be honest. It's really finding one that works well for you. I can tell you my one that I have here personally at home is a water pick. My daughter lives in Canada. She can purchase Prevident 5000 over the counter and gets it for me. Great, Lisa. That is awesome. I think it's a great, great paste. Is there any advantage to brushing your teeth in the evening before bed using only alkaline water at 9.5 pH or higher for brushing and rinsing? I also recommend using alkaline water in the water pick as well. I have heard that, but to be honest, I haven't researched the alkaline water as much as we look at the other protective factors like the fluoride and things that we have in there in salivary composition. I'm not as familiar with the alkaline, but I would be happy to look into that. And you're welcome to email me the address we had on there. So, what is your recommendation on xylitol tablets half hour after meals? I'm a big fan of xylitol. I'm a big fan of xylitol tablets. I'm a big fan of the gums, the mints, obviously within reason and how you use them. I also look at things like probiotics. I think they do have a good benefit factor for a lot of our individuals and a lot of our patients. I'm a big fan of xylitol and xylitol tablets after meals. I think it does have the protective factor that helps not only against the bacteria, but also to stimulate the salivary flow. Let's see. Somebody already asked me and I answered it. Are you a fan of oral probiotics? I am. My grandson's saliva tested highly acidic. Can you recommend something in addition to MI paste and products? I would ask if you're using professional applied fluoride, which I assume you probably are. I think MI paste products are fantastic. I would recommend, depending on your grandson's age, also using that MI paste with something like the soft picks or an interdental brush to really get it interproximal just a touch more than brushing it on alone. Let's see. Does having dental implants make a change the way one flosses? In my opinion, it does, because that is going to, you're going to want to wrap that floss a little bit tighter around than you would think an average C shape from the tooth would be. So to be honest, I really like the water flossers around it, but I also, if I'm using floss, I like the woven floss. because of the texture of it, I think it's going to help to clean off a little bit better. Wonderful. So I think that is all the questions that I have on here. And again, please don't hesitate to reach out to me. It's been an absolute pleasure. I want to thank Viva Learning for hosting me here as well. And if you have questions, again, my email is there on the screen. And thank you once again.